Hello everyone, how are you doing? Hope you guys can see me and hear me clearly. Just give me a few seconds to get started. We have an interesting class lined up today, and that is Cancers in Surgery Part 3. And today we will be discussing some cancers which are very important for undergraduate as well as NEET PG level, but we don't really focus on them. So yesterday we finished thyroid cancers. Today we will go one step ahead. We'll do some of the other thyroid cancers like medullary thyroid carcinoma, as well as the other endocrine tumors like pheochromocytoma, adrenal tumors, parathyroid tumors, Men's syndrome, undoubtedly important. So just give me a few seconds to get started. If you guys can see me and hear me clearly, please give a thumbs up. I can see you guys in the chat on my phone. Yes. Okay. So as people are joining in, let me give you a little bit idea of who we are, what we do, what I do on the Unacademy platform. I am Dr. Amrit Nasta. If you wish to learn more from me, you can use my referral code, that is 10 surgery, and that will get you a discount for the different subscriptions on the Unacademy platform. I am a bariatric surgeon from Mumbai, and I will be covering surgery for all students of NEET PG on the Unacademy platform. You can easily download the learning app and you can follow my profile. There are a lot of educators like me covering different things on the platform, which will help you score well and get a good rank in your NEET, INI, FMG and other competitive exams. There is also a plus with an iconic subscription where you get benefits of the plus platform as well as benefits of prep ladder, so you get dual benefits. You can subscribe for that. There are different subscription models for different duration. If you use my referral code, that is 10 surgery, you will get a discount. Yeah. So depending on what exam you are targeting, you can choose the subscription model of your liking. All right. Okay, enough people have joined in, so just give me a thumbs up if you guys can hear me clearly, and then I will begin. So try to be interactive, try to solve as many questions as possible. There are a lot of small important points in each of the topics that I'm going to be covering. Okay, alright. So let's begin the class. So let's begin with medullary thyroid cancer. I am asking you the true statement. What is the true statement about medullary thyroid cancer? Seen in men 1 syndrome. Tumor shows warm nodularity on thyroid scan. We did thyroid scan yesterday in some parts. Diarrhea is common and it is due to serotonin secretion. The familial variant is bilateral and multifocal. So let's see what you guys think about this. I'm asking you the true statement. Is medullary thyroid cancer seen in men 1 syndrome? Or is it men 2? Or is there a men 3? Is there anything like men 3? Yeah, so whoever is responding, I can see you in the chat. Okay. So first things first, medullary thyroid cancer, it is not seen in men 1, so this is incorrect. It is seen in men 2A and men 2B. So it is seen in 2A and 2B, right? Tumor shows warm nodularity. What is the cell of origin of medullary thyroid cancer? Yes. What is the cell of origin of medullary thyroid cancer? You can write in the chat box because I can see what you are writing on my phone. And what is the cell of origin? So yes, parafollicular or C cells. C cells produce thyrocalcitonin. They do not produce thyroxine. They do not have iodine production. They are not going to have uptake, so they are not going to be warm. This is wrong. They are going to be cold because they are not going to have thyroid uptake or iodine uptake. So on scan, they are going to appear cold. Diarrhea is commonly seen due to serotonin secretion. First things first, do you see diarrhea in medullary thyroid cancer? Is it seen? Forget the common part. Let's say the word common was not there. Do you see diarrhea in medullary thyroid cancer? Yes, Nural, Kurinchi, Sampath. So diarrhea can be seen, no doubt about it. It is because One of the reasons is maybe serotonin secretion. That is one of the reasons. But it is seen in only 30% population. So it is not commonly seen. Even if you didn't know anything, familial variant is bilateral and multifocal. This is correct. Of course, familial cancers are going to be more aggressive. The same holds good even for breast cancers. Familial breast cancers are more aggressive. They are associated with other cancers because they present with the mutations from birth. So the progression is going to be much more. They occur earlier. They are seen in younger population compared to sporadic, just like breast. Similarly, medullary thyroid cancer, very similar. So what are the important points that we need to know about medullary thyroid cancer? This, you can make a note of these things, okay, because YouTube presentations you can't download, so important points you should always note down in YouTube classes. This is going to be important for NEET as well as for undergraduates, for your final MBBS, third MBBS, because thyroid they can always ask you, right? So what is the cell of origin? Cell of origin are your C cells or your parafollicular cells. Understand, most cancers in the body are sporadic. Okay, 80 to 90% of medullary thyroid cancers are going to be sporadic. They are seen in Men's syndrome, no doubt about it, but that's a very small population. So if someone has a medullary thyroid cancer, you cannot jump the gun and say he has Men's syndrome. ऐसा नहीं है. Okay, familial is seen in a very small population where it is associated either with MEN2A or MEN2B. Is there any other syndrome associated with medullary thyroid cancer apart from MEN2A and MEN2B? Yeah. Any other syndrome, familial syndrome, apart from MEN2A and MEN2B that is seen with medullary thyroid cancer? There is a syndrome. It's called FMTC. ये पूछा नहीं है आज तक. FMTC. FMTC simply stands for familial medullary thyroid cancer. It is nothing but where you have medullary thyroid cancer, you have the mutation. What is the mutation that you see in medullary thyroid cancer or in Men's syndrome? 2A, 2B. What mutation normally gives rise to Men's syndrome or medullary thyroid cancer? Yeah, it is your RET mutation, RET proto-oncogene, that's right. So someone who has an RET proto-oncogene mutation, who has medullary thyroid cancer, it is familial, but he does not have other features of MEN2 syndrome that will be called as familial. So familial means only MTC and not the other components. Only MTC, not the other components. Diarrhea is because these tumors tend to produce pyhydroxytryptamine, prostaglandin, but only in 30% population, so it is not universal. Okay, हर किसी medullary thyroid cancer को नहीं होने वाला diarrhea. What is the tumor marker for medullary thyroid cancer? Yeah, what's the tumor marker? While you write tumor marker, these are aggressive tumors, so they will have both hematogenous metastasis and lymph node metastasis. Commonly, they are very aggressive, unlike our papillary and follicular. So there is calcitonin, which is the other one. Neural punam, एक है calcitonin, which is the other tumor marker. Apart from calcitonin, other second one सारे आने चाहिए. Tumor markers तो easily आएंगे, आने ही चाहिए. Other tumor marker, anybody? It is CEA, carcinoembryonic androgen. CEA is a tumor marker for which other cancer apart from thyroid, medullary thyroid? ये छोड़ के which other cancer in the body? I can think of one more where CEA is a tumor marker. CEA is a tumor marker for pancreatic. No, pancreatic is not CEA. Pancreatic is CA19-9. CEA is in colorectal cancers. Colorectal cancers. Ovarian also, very good. In surgery, colorectal. What is the special stain that we use for medullary thyroid cancer on histopath? Is there any special stain? Can you identify a medullary thyroid cancer on simple H&E stain? Congo red. Okay, why Congo red? That's an interesting one. Congo red. It's a very unique stain. Amyloidosis. Okay, it's not for amyloidosis. The tumor produces amyloid. So you have amyloid stroma in the tumor. Amyloid stroma. So it is not a tumor of the follicles. The follicles will be normal. I told you, follicles will be normal. This is a tumor of the parafollicular cells. So those cells will start getting arranged in sheets and cords, and they will produce amyloid. This amyloid can be stained just like your normal amyloid with the Congo red stain. And what do you see in Congo red stain? What is the appearance on Congo red stain? क्या दिखेगा कैसे? When you see it under polarizing microscope, आना चाहिए, because they will give you a thyroid specimen with a unique color, unique appearance. It is going to be polarized microscope. Excellent, apple green. Very good, Noorel. Excellent answer. You get apple green birefringence. I'm just trying to do, if you must have noticed, a lot of clinico-pathological correlation. Apple green birefringence. Because these things, pathologists will only teach you this. Okay, they will not teach you the clinical part. They will not focus on the treatment, the tumor markers. They will focus more on the pathology. What I want to do is integrate so that you remember once and for all everything about medullary thyroid cancer. If someone has a MEN2 syndrome, MEN2, those people should undergo a prophylactic total thyroidectomy. मतलब if I have the mutation, that is my RET mutation, अगर मुझ में है RET mutation, then even before I get the MTC, I should undergo prophylactic thyroidectomy. Anybody can tell me at what age? What age? By what age should I undergo prophylactic total thyroidectomy? Prophylactic, मतलब even before the MTC is developed. 5 years meant to way. Excellent, Noorel, that you are giving some great answers. Simple way to remember, within 5 years. One number if you want to remember, within 5 years. 2A, 2B, correct, they are different. Simple way, up to 5 years you should undergo prophylactic total thyroidectomy. For sporadic MTC, what is the treatment? Sporadic, this is for familial. Sporadic MTC के लिए क्या करेंगे? You will do total thyroidectomy. Anything else apart from total thyroidectomy? Do I have to do lymph node clearance like I did for papillary, where I wrote plus minus? So here you will always do, because they are aggressive tumors, always you will do level 6 clearance or central compartment clearance, always. So here you have no option, यहाँ पे करना ही है. Okay, any doubt about MTC? Important cancer at different stages of your exams, which we don't really focus on too much. Every relevant point I have covered from presentation to diagnosis to treatment. इसमें कोई सवाल आएगा, ऐसे ही सवाल आएगा, पैथोलॉजी तक आ जाएगा. Remember diarrhea, 30%. Okay. Alright. Yesterday we couldn't cover thyroidectomy as a procedure. Of course, this is an important procedure. So I want you to tell me incorrect statement about thyroidectomy technique. Incorrect statement. First structure that we ligate in thyroidectomy is a middle thyroid vein. If I accidentally remove parathyroids, they may be reimplanted in the sternomastoid. Superior thyroid artery is ligated individually near the upper pole. Inferior thyroid artery is ligated individually away from the lower pole. Important question. They love asking thyroidectomy. 3 questions will come from thyroid in whichever exam you give. Expect one of the questions to be on thyroidectomy because there are a lot of new things happening. Usually brachioradialis. Acha. Yes, anybody else? Amit, Poonam, anyone else wants to give? Kurinchi Sampath? He's saying usually brachioradialis. मैंने तो may भी लिखा है यहाँ पर. May be reimplanted in SCM. I have not written always. Okay. First structure to be ligated is middle thyroid vein. This is correct. You have doubt in this, we will see it later. Superior thyroid artery is ligated individually near the upper pole. Now understand, why are we ligating the arteries? What is so important about that? The superior thyroid artery and the inferior thyroid artery. Now understand, all artery surgeries are to do with protecting the nerve. In this case, I don't want any nerve to get injured. Superior thyroid artery will be ligated close to the gland because the external laryngeal nerve is away. So I don't want to ligate it away. Recurrent laryngeal nerve runs behind the gland. Okay, runs behind the gland. Ligament of Berry, site where it will get injured likely. In earlier days, we used to ligate it away. This was older teaching. Nowadays, what Bailey says, even this should be ligated close. So both superior and inferior thyroid arteries should be ligated near the poles, upper pole or lower pole. It's called ligated in continuity. Ligated in continuity. So away from the pole, this is the incorrect answer. You said accidentally remove parathyroids may be reimplanted SCM. This is correct according to Bailey. They may be reimplanted. Understand? If I am doing a thyroid surgery and I remove the parathyroids and I realize I can put it in the SCM also. It's more important if I am doing total parathyroidectomy for a parathyroid disease itself that I put it in the forearm. There is a reason for that. And I'll answer that question when we do parathyroid surgeries. As to why, if I remove accidentally in thyroid surgery, I can put it in the SCM, no problem. But if I'm doing parathyroid surgery and I want to put something back, I will always put it in the forearm, brachioradialis. There is a reason for that. I will tell you in the class when we reach there. But definitely there is a reason. Okay, so I already told you these 2 points. Please remember important points. The second point is the new point. When I was in MBBS, when I was in 2005, that time BD Chaurasia said inferior thyroid artery ligate away. That has been abandoned. Bailey clearly says inferior also close to the inferior pole, individual branches to be ligated in continuity to preserve blood supply to parathyroids. Parathyroid का blood supply किधर से आता है? What is the blood supply of parathyroids? Yeah, is there something like a parathyroid artery? And where does it come from? Yeah, blood supply of parathyroids. It is inferior thyroid artery. Yes, inferior thyroid artery. तो अगर मैंने inferior thyroid artery को very far away from the gland ligate कर दिया, that's right, Kurinchi. If I ligate it very far away from the gland, obviously thyroid blood supply will go, but parathyroid will also go. Okay, in thyroidectomy, I don't intend to do anything to the parathyroids. Okay, and this is something new. If you have doubt in identification of recurrent laryngeal nerve, you should use nerve monitors. In which other surgery do we use nerve monitors to identify the nerve if we have a doubt? Which other surgery? One is thyroidectomy for recurrent laryngeal nerve. Any other surgery you have heard? Use of nerve monitors? Important. It's more important here, but even in that surgery, it's important to identify the nerve because the nerve is the most important component in that surgery. Yeah, anybody? Which other surgery can we use nerve monitors? I'll give you a clue. It is to identify the facial nerve. In which surgery? If I'm doing superficial parotidectomy, that's right, superficial parotidectomy. उसमें भी I use nerve monitors if required. If I have a doubt, if I can't trace the nerve, I can do stimulation. If there is any structure, I can stimulate it and see, okay, is there twitching in the distribution of that nerve? Easy way. Now coming to Men syndrome. So today's class is mainly about Men syndrome and adrenal gland, mainly. MTC is a part of Men syndrome. So I want you to tell me the incorrect statement about Men syndrome. Incorrect. Autosomal dominant. Hyperparathyroidism is seen in men 1 and men 2B. Castronoma is the most, MC is most common. Most common endocrine tumor of pancreas in men. Men here means Men syndrome, not man. Pheochromo is seen in both 2A and 2B. Yeah. Nurel says B. Anybody for any other answer? It's an interesting one. Is it autosomal dominant? I have given you a trick about autosomal dominant. Okay, Amit is saying C. Gastronoma is the most common. Kurunchi is also saying B. BCB. Is it autosomal dominant? The inheritance pattern? Yes, AD. Okay, very good. It is autosomal dominant. Like we had BRCA, like we had familial adenomatous polyposis coli. Similarly, Men syndrome. All familial syndromes, familial cancer syndromes are going to be autosomal dominant, no doubt about it. All familial cancer syndromes. Okay, take it in writing. That's why they are called familial, because they run in families. What will run in families? Autosomal dominant diseases. Recessive diseases don't run in families because they skip generations. Okay, they will not manifest because you need both parents to be carriers for a recessive disease to manifest. Dominant diseases always run in families, 50% offsprings. Hyperparathyroidism. Yes, Mir, you are saying this is wrong. Why is this wrong? Hyperparathyroidism, it is seen in what? It's not seen in men 1 or not seen in men 2b or what? Mir says B. Why? Yeah, it is seen in men 2a. Very good, men 2a. We will clear all doubts about men syndrome today. Don't worry about it. सारे के सारे क्लियर करेंगे. आज के बाद मेन सिंड्रोम में तुमको जरा भी शक नहीं होना चाहिए, बिल्कुल भी नहीं. Parathyroid adenoma. Yeah, adenoma will cause hyperparathyroidism only, isn't it? I have just said hyperparathyroidism. Gastronoma is the most common. Yes, please understand. Overall, in pancreas, the most common endocrine tumor is not gastronoma, it is insulinoma. Overall. But in men syndrome, where you get pancreatic endocrine tumors, their gastronoma is the most common. FEO is seen in both, this is correct. What other cancer is seen in both men 2A and men 2B? FEO and what? Which other cancer is seen in both 2A and 2B? One is FEO. Which is the other? Yeah, which is the other one? Apart from pheochromocytoma that is seen in both 2A and 2B? Yeah, very good, excellent. MTC. So medullary and pheochromocytoma are both seen in 2A and 2B. So this is the slide, important slide. Yes, Dr. Kostov, that's correct. Important slide. Simplified men syndromes. First, I have written autosomal dominant. सारे के सारे और autosomal dominant. What is men 1? Men 1 is the rule of 3 P's. What is the other name of men 1 syndrome? Anybody? It has another name. By the way, MEN stands for multiple endocrine neoplasia. Just for your information, we take it for granted, but we should not. Multiple endocrine neoplasia. उसका मतलब ये है. Multiple endocrine systems get tumored, right? Very good. Werner syndrome. So it is the rule of 3 P's: pituitary tumor, parathyroid tumor, and pancreatic tumor. Pancreatic endocrine, not exocrine. Pancreas में बहुत सारे tumors होते हैं. We are talking about endocrine tumors of pancreas because this is an endocrine neoplasia. This is men 1. Men 2 has A and B. First things first, both have RET mutation. What is the mutation in men 1? Men 1 में कौन सी mutation होती है? थोड़ा थोड़ा पैथोलॉजी आना चाहिए. Men 1 में कौन सी mutation होती है? Men 1 syndrome. It is in which protein? MENIN. Yeah, excellent. Menin gene, coding for menin protein. Okay. And men 2A and 2B is ret mutation. Alright. So 2A, 2B, first thing you need to know, common. MTC and pheochromocytoma is common to both. In 2A, additionally, you have parathyroidism. It can be hyperplasia, can be adenoma. Usually, in the endocrine men syndromes, usually it is hyperplasia in both. Usually it is hyperplasia. Adenomas are usually sporadic. Okay, so if someone has a parathyroid adenoma, it will usually not be a part of a syndrome. Because neoplasia, in this case, means hyperplasia. So usually it will be hyperplasia of parathyroids. 2B में, apart from MTC and pheo, you get mucosal neuromas, typically at the lips or tongue. So it's a very classical appearance. There's a picture of this in Bailey. They have shown the lips of the person, the tongue of the person. The tongue is a little swollen, lips are a little swollen. He has Marfanoid features. You know those extensible joints and all those things. Marfan syndrome पढ़ते हैं medicine में. they have a very classical appearance. इस पे MCQ आएगा देखना, clinical MCQ on meant to be. They'll give you a picture of a marfanoid looking or a marfanoid features, high arc palate but swollen lips, swollen tongue or tumors on the tongues, mucosal neuromas, and they'll give you some history. He has hypertension, he has palpitations. You will wonder what the hell is happening. Okay, why is he having hypertension and palpitation? Because of pheochromocytoma. Alright, so these are the common things of men 1, men 2A, 2B. Men 1, the rule of the 3 P's, pituitary, parathyroid, pancreas. 2A, 2B both have pheochromocytoma and medullary thyroid cancer. 2A has parathyroid extra, 2B has neuromas extra. और भी चीजें हैं छोटी मोटी काम की है, इसमें मिस्टेक नहीं होगी, MCQ इसमें आएगा. We will discuss them a little bit more in detail because you should have no doubt about these questions. No doubt. This is, I believe, the most expected question. Which would be sort of rank defining. Sort of. Because this overlaps medicine, surgery, pathology. Different subjects with this question has an overlap. It is not pure surgery. Today's class is not pure surgery. You will see it's more of pathology and medicine. As the class grows, you will realize. So in men 1 syndrome, earliest manifestation. Questions look very easy on the face, but even I wrote in the Telegram channel, every point there are bundles of MCQs that can be created in this. Yeah, so some Nurel is saying renal stones, bone pains, peptic ulcers, asymptomatic hypercalcemia. Okay, Nurel has been the star so far, but have they given the correct answer? Sonali also says D. Okay, nobody for bone pains. I told you what is there in men 1. Men 1 rule of 3 P's: pituitary, parathyroid, pancreas. I told you pancreas is what? Gastronoma. That is the most common one, gastronoma. तो गैस्ट्रोनोमा से पेप्टिक अल्सर हो सकते हैं, पैराथायरॉयडिज्म से रीनल स्टोन हो सकते हैं, बोनी पेन हो सकते हैं, which is the most common or the earliest is asymptomatic hypercalcemia. So I'll tell you what Bailey says. What Bailey says about primary hyperparathyroidism, okay, or men 1 syndrome. What Bailey says, in earlier days people would present with symptoms of hyperglycemia. Most common was renal stones. But now, before the renal stones are diagnosed, people are diagnosed because of hypercalcemia. Like they do some blood tests, calcium comes abnormally high, and then they are investigated. What I'm trying to say is anyone with asymptomatic hypercalcemia, unexplained hypercalcemia, not taking medicines, no hypervitaminosis D or anything like that, think about Men's syndrome. 80 to 90% people will be diagnosed with this. Of course, if not this, then parathyroidism. So in Men's syndrome, I told you the MEN1 gene for the menin protein. The earliest problem or the earliest tumor and the most common tumor is going to be parathyroid. Okay, that's why young age of symptomatic hyperparathyroidism. Young age. This is the first manifestation. Not everybody will have pituitary, not everybody will have pancreas. In pituitary, the most common is prolactinoma. In pancreas, the most common is gastronoma. Okay, these people also have carcinoid tumors, usually in the lung or in the thymus, bronchial carcinoids or thymic carcinoids, but they are not so common. The rule is PPP, so it is pituitary, pancreas, parathyroid, but parathyroid is the most common. It is multiglandular, means hyperplasia, not adenoma. Usually it's not going to be adenoma. Of course, the treatment for parathyroid hyperplasia is going to be 3.5 or total parathyroidectomy. You know you have 4 parathyroids. Either remove all 4, implant some part, or do 3.5. Leave behind half. 3.5 parathyroidectomy. New question. Most common cause of death in Men-1 syndrome. Anybody? Most common cause of death. Which of these will kill the patient? Yeah, most common cause of death. Is it the hyperparathyroidism which will kill him? The prolactinoma? The gastronoma? Or what? Yeah. Most common cause of death. ये पूछा नहीं आज तक. I have not seen this question. Insulinoma तो होता ही नहीं है. Usually gastronoma होती है. So insulinoma is not correct. There is no insulinoma. Yeah, most common cause of death in men 1, gastronoma. Gastronoma will kill the person. How? It is because of malignant carcinoids. Malignant carcinoids, either the bronchial carcinoids or if the gastronoma turns malignant. Not prolactinoma, not hyperparathyroidism. It is because of malignant carcinoids. This is the most common cause of death. Not yet been asked. Expect this to be asked. Something like this. Okay. Again, new question. I made this question yesterday itself. Identify the incorrect statement. We are mainly talking about Men-2 syndrome now. Men-2, both A and B. Occurrence of medullary thyroid cancer in patients with Men-2 and Men-2B is 100%. Means if I have the mutation, 100% I will get the cancer. Recall we did BRCA mutation and we saw what was the percentage of cancer if someone has a BRCA mutation. Hirschsprung is associated with Men-2A. Hirschsprung? MTC in Men-2A is more aggressive than Men-2B. Pheochromocytomas are benign in Men-2A and B. Yeah. Dr. Kaustubh says A, 100%. Kurinchi says C, MTC in Men-2A and 2B. Yeah. Nurel also says C. Yes, what does Mir Patak, Sonali and Poonam Chaudhary, what do they have to say? And the others. Important question. There are so many MCQs and important concepts in these topics. It's not even funny. And they look so short and concise on the face of it, but there is so much to do. So much. I thought I will have no matter to take a 1 hour class. But now I feel in 1 hour I won't be able to finish half the things I wanted to. ऐसा मुझे लगता है. Okay. So first things first. In both Men-2A and 2B, the most common is medullary thyroid cancer. This is the most common of the 3. Okay. In Men-1, it was parathyroid. In Men-2, it is medullary thyroid cancer. This is the most common one. Then pheochromocytoma, and then depending whether it's 2A or 2B, parathyroid will be there, or marfanoid habitus and neuromas will be there. If I have the RET mutation, yes, the occurrence is 100%. 100% people with red proto-oncogene mutation with the Men syndrome are going to get medullary thyroid cancer in their life. Not just life, in early life. In early life. Remember when we did BRCA mutation? If I am BRCA1 positive, lifetime risk was 50 to 80%. If I was BRCA2, it was 80 to 90%. What is the lifetime risk of colonic cancer if I am FAP positive? Anybody? FAP? If I have familial adenomatous polyposis, what is the lifetime risk that I'll get a colorectal cancer? This is how you have to study and correlate. Yes, absolutely right. 100% there also. 100%. So there also they suggest prophylactic proctocolectomy. Okay, prophylactic proctocolectomy. Like here I told you to prophylactic total thyroidectomy. Prophylactic proctocolectomy. Same. Needless to say, FAP kinetics pattern is going to be again autosomal dominant. I hope your life has become a little easy after getting a correlation of all different diseases which are actually very similar. That is the beauty of pathology and medicine. Okay, Hirschsprung is associated with men 2A. This is correct. Hirschsprung can be seen. It is an extra manifestation, bowel manifestation. It can be seen. Even if you are not sure about this, this is obviously wrong. MTC in men 2A is not more aggressive. It is less aggressive. Okay, men 2B is the worst. This is the worst of the men syndrome cancers because in this patient MTC होना ही है and it will happen by the age of 1 year. So if I have a meant to be mutation in the family, the screening of men gene or RET mutation should be at birth. I have to screen. So if my father was diagnosed with meant to be and it's autosomal dominant, which means 50% chance I will get it, it has to be diagnosed at birth because the risk of medullary thyroid cancer is up to the age of 1 year. एक साल में उसको MTC हो जाएगा. And remember I told you familial cancers, bilateral, multifocal, more aggressive, poor prognosis. Right? Poor prognosis. So about MEN2 syndrome, I already told you this. 100% in both. 100% MTC. Bilateral or unilateral pheochromocytoma in both, but this is second common. Here you have parathyroid adenoma or parathyroid hyperplasia, either can happen. Here you will have mucosal neuromas. Here you will have mucosal neuromas. And because MTC is 100% in men 2A, you will do thyroidectomy by the age of 5 years. In men 2B, you will do thyroidectomy by the age of 1 year. Okay, by the age of 1 year. Mutation I told you, RET. What will present first? MTC will present first. In both. दोनों में. Okay, here you have Hirschsprung's disease. Here you have something else. Anybody can tell me what is the equivalent of Hirschsprung in men 2B? Not given in Bailey, only given in Sabiston. In men 2A, you get Hirschsprung. What do you get in men 2B? It's not Hirschsprung, but it is to do with the colon only. Yeah, anybody? What is the colonic manifestation of men 2B? Given in Sabiston, it's not given in Bailey. Thoda high level. Megacolon, Poonam, that is an amazing answer. Amazing. I am very impressed. It is megacolon. Okay. Hirschsprung is congenital megacolon. Okay, it has those absent ganglia in the lower part and all those things. इसमें वो नहीं होगा. Colonic dilatation होगा or constipation होगा, but it's not going to be Hirschsprung, which means if I do a rectal biopsy, those aganglionosis will not be there. But megacolon होगा. Any doubt on any of the men 2 syndromes? Okay, men 1, men 2A, 2B, absolutely clear. No doubt about it. Men 1 I already did. Okay, now coming to parathyroid. Understand, hyperparathyroidism rarely will be a part of men syndrome. Mostly it will be sporadic. So I'm talking about sporadic hyperparathyroidism. Sporadic. What is the most common presentation of symptomatic primary hyperparathyroidism? Primary का मतलब है the PTH is produced increasingly because of a fault in the parathyroid. So the parathyroid is at fault. That's why he is having increase in PTH. That is the meaning of primary hyperparathyroidism. So what is the most common presentation? Bone disorders, renal stones, muscle weakness, mental impairment. इसका एक वो there is a phrase, bone stones, psychedelic moans, overtones, muscle groans, abdominal groans, ऐसे there is a saying for that. जो पुराने ज़माने में सही होती थी. Now it's not believed to be true anymore because again primary hyperparathyroidism is again normally diagnosed asymptomatically because of hypercalcemia most of the times. You do some test. Normally for surgery, before surgery we do electrolytes. Suddenly you see calcium has come 12, 13. You're scared. Oh my god, why is the calcium 13? You do PTH, PTH is high. So you're scared. Why should the person's PTH be high? In that case, you diagnose primary hyperparathyroidism beforehand. Okay. Yes, Koyal Mir. Any answers? Punam, most common presentation of symptomatic primary hyperparathyroidism. So if he is symptomatic, usually it will be renal stones. Okay, I'll give you a very simple way to remember primary hyperparathyroidism. Anybody can tell me what are the abnormalities, blood abnormalities, urine abnormalities that are seen in primary hyperparathyroidism? Easy way to remember. Yeah, you just have to remember this. It's more medicine than surgery, I understand. It's more medicine than surgery. The surgical role is very limited, but we need to know so that our medicine load is a little less. What are the abnormalities? Increase calcium, decrease phosphate. Okay, I'll tell you what. We always get confused. Phosphate increase, phosphate decrease. You just remember primary hyperparathyroidism. PTH increases, so you get increase in serum calcium. Okay, and you get increase in urine phosphate. Bus. That's all. Increase in urine phosphate. And there is one more. What happens to vitamin D? What happens to vitamin D when the PTH increases primarily? ये तीन चीजें primary की याद रखो बस. And the clue is that something will increase. What will increase? No, vitamin D doesn't decrease. It increases. Decrease. Sir, क्या decrease बोल रहे हो तुम लोग? Not decrease. Increase. Everything I am showing is increase. Increase in gut absorption of vitamin D. Okay, so everything increases, but in serum, urine, and gut. Increase serum calcium, increase urine phosphate. That is why if the urine phosphate will increase, then the serum phosphate will decrease. ना वो तो है ही, तो serum phosphate कम होगा. Correct. Gut absorption of vitamin D increases. That is primary hyperparathyroidism. These are the blood, urine, and gut changes because of increase in PTH primarily. Obviously, if the urine phosphate will increase and the serum calcium will increase, he will have bone resorption, he will have renal stones, muscle weakness, mental impairment. Why exactly it happens, they don't know, but they are also seen. They are all of them are seen, but the most common is renal stones. You get one more renal manifestation. Anybody knows? Apart from renal stones, what is the other renal manifestation of primary hyperparathyroidism? Apart from renal stones, which is the other renal manifestation? You get something called as nephrocalcinosis. Please understand, nephrocalcinosis is not renal stones. Huh? It is deposits of calcium in the substance of the kidney. Nephrocalcinosis. Okay, I'll tell you the surgical component here. Where are my parathyroids? So this is my thyroid over here, butterfly shaped. Parathyroids, I have two pairs, superior and inferior. The inferior are at the lower pole. So lower pole of thyroid has the inferior parathyroids. Superior parathyroids are located. So this is my inferior thyroid artery going like this. ऐसे जाती है. And it is crossed by the recurrent laryngeal nerve. Like this. The superior parathyroids are located within 1 centimeter of this crossover. Within 1 centimeter. So understand, superior parathyroids are not at the upper pole. They are somewhere in the middle only, but they are variable in position. So during surgery, inferior parathyroids I can locate easily because I know where they are, consistent. Inferior, 1 centimeter along junction of inferior thyroid and recurrent laryngeal nerve somewhere here. They can be variably placed. Now, I told you primary hyperparathyroidism, usually it is sporadic. Usually it is sporadic, again 80% of the times, 80 to 90%. Sporadic means because there is a parathyroid tumor. Here it is adenoma. In Men's syndrome, it is hyperplasia. Usually hyperplasia. Obviously, the implication is adenoma है तो एक gland में होगा, hyperplasia है तो सारे gland में होगा. Treatment will be different. You know what the treatment is. Most common renal colic if symptomatic. Bone, ये भी पूछा नहीं है. Bone. Which bone gets affected? Most common distal radius. Okay, distal radius, MCQ. Diagnosis, I told you will have increase in PTH, of course, increase in serum calcium, decrease in phosphate. I don't want you to remember that. Increase in urine phosphate, and increase in gut vitamin D. That you're not going to check, but that is a pathological change. Everything increases. Just remember primary. Surgery sake, just remember primary. और कुछ नहीं चाहिए अपने को. Okay, this is a important question. It's been asked before. पहले पूछा ये. It's not new, but important. Most reliable and accurate technique of parathyroid localization. First, understand why do I have to localize the parathyroid? I just showed you. Why do I have to localize the parathyroid? Anybody? Inferior, though I know where they are going to be. Superior, even if they are, let's say one is over here, one is over here. Why do I have to localize? ये जो फंडे हैं ना, ये आपको बुक पढ़ के नहीं आएंगे. और एक बार ये फंडे समझ गए, like you understood men 1, men 2A, 2B, men 1 is parathyroid, men 2A, 2B is MTC, 100% penetrance. ये फंडे समझ में आने चाहिए. Okay? Most people have answered correctly. Yeah, Sesta maybe. Bailey line this is given in Bailey. But can you tell me, localization means what? Means I have to see where parathyroid 1, 2, 3 and 4 are. Is that what I want to see? वो तो मुझे सर्जरी के टाइम पे दिख जाएंगे ना. दिख जाएंगे ना जब मैं सर्जरी करूंगा. I will see where the parathyroids are. So what is this localization? Anywhere else we have done localization in your life? We never do localization. Why do I want to localize? Yeah. Yes, Nurel. Poonam. Localization for what? System में भी मुझे पता चल जाएगा. There is one parathyroid here, one over here, one over here. But the area is so little anyways. Yeah, so they are going to be related to parathyroid only. So what? When I do the surgery, I will find them. ना ऐसा थोड़ी है कि the localization will tell me, oh, one is near the middle part of thyroid. उसके पीछे जाओ. Near is saying metastasis. Metastasis के लिए थोड़ी कर रहा हूँ मैं. Parathyroid adenocarcinoma. It's not for metastasis. Poonam is saying mitochondria. I like the way you are thinking, Mir. Thinking is good, but answer is not. They are small, no doubt. But when I do the neck exploration, I will know ना where they are. ऐसा तो नहीं है कि कहीं आसमान में खो जाएंगे. When I say localization, I want to localize which of the parathyroids has the adenoma. Please understand this. Which of the parathyroids has the adenoma? Parathyroid will have two problems. Either there will be adenoma or there will be hyperplasia. If there is hyperplasia, usually all four will be hyperplastic. Anyways, if there is hyperplasia, you have to remove all four. सारे के सारे निकालने. 3.5 parathyroidectomy. Adenoma will be in one of the glands. Let's say it is in number 4. For example, how do I know beforehand which of the 4 has the adenoma? That is the reason for doing localization. When I am doing localization, the intent of localization is to identify which has the adenoma, because then I will only remove the adenoma. I don't have to remove all 4. I hope you got the fundamental. The reason for localization is to identify which of the 4 parathyroids are pathological. Because if 1 or 2 are pathological, they will be localized better, they will light up better, system EV will get assimilated better in the mitochondria. So I will know which ones I have to take out. Okay, so I know which ones I have to take out. If I am doing 3.5 parathyroidectomy, localization has no role. उसमें क्या करना है, सारे निकालने ही तो है, मुझे पोजीशन थोड़ी देखनी है पैराथायरॉयड की, मुझे देखना है कौन सा पैराथायरॉयड हैज टू बी रिमूव्ड, which one has the adenoma. I hope you got what I'm trying to say. It's not sounding too high funda, but this is the intent. All of these, cestum EV, 4DCT, we'll see where is the adenoma. Hyperplasia हो सकता है, but those are going to be in usually in all four parathyroids. एक दो में नहीं होगा, वो भी पता चल जाएगा. If it's hyperplasia, भी पता चल जाएगा which one has hyperplasia. Accessory parathyroid, very far-fetched. Most common site of accessory parathyroid, anybody? Most common site, since Mihir mentioned that, most common site of accessory parathyroid. Yeah, anybody? ये आज तक पूछा नहीं है. They always ask most common site of accessory thyroid or ectopic thyroid, that is lingual gland, or thyroglossal cyst. Parathyroid का accessory कभी पूछा नहीं आज तक. Anybody? Anybody? Most common site of accessory parathyroid. No answer. Noorel also doesn't know. Mir just mentioned, passing by me. I'll give you a clue. It's a ligament, and it's not Berry's ligament. It's a ligament in the neck. Okay, find it out. Thymus, you're close. Poonam, you're close. You're close. It's a ligament. Find out. Okay. Anyways, these are non-invasive. Cestum EB and 4DCT. Angiography or venous sampling are invasive. So they are rarely done. But again, they are done to identify which of the four parathyroids is abnormal. Now understand. Now you'll understand this question better. In patient undergoing total parathyroidectomy, biochemical change observed is. Please understand, this what you see is not applicable if I am doing only the adenoma wala parathyroid removal, adenoma excision. Then this change has no bearing. Because if I am removing only one parathyroid, other three are there, then this change will not happen. So this is only if I am doing total parathyroidectomy or say 3.5 parathyroidectomy. उसमें ये change आएगी. Where before surgery I check, so pre-surgery or pre-op I check serum PTH, and then after some time I check, means after surgery, after excision I check again. After 5 minutes or 10 minutes I check serum PTH and I want to look for a drop. The fact that there is a drop means I have removed all the parathyroids. That is the meaning. Because here I want to do total. I cannot leave behind one parathyroid. फिर उसको problem वापस होगी. Because here I am doing total means I am doing it for hyperplasia of parathyroid. I am doing it for hyperplasia, where all four are hyperplastic. A, B, C, D, सारे के सारे hyperplastic. Akanksha Nag has come late in the day. Akanksha, I was looking for you. Class is almost over. Yeah. So answer is 50% drop in PTH in 10 minutes. This was asked in NEET PG. This is called Miami criteria. Okay, this is called Miami criteria. So there are only two surgeries that we are going to do. Okay, only two surgeries for parathyroids. If there is an adenoma where only one or two parathyroids are affected, we do what is called as minimally invasive parathyroidectomy, means chota incision. Incision of size less than 3 centimeters in the neck. It can be done endoscopically also. If it's hyperplasia, means all four, then you will do 3.5 parathyroidectomy or total parathyroidectomy. Now I hope you know, for adenoma, I do localization studies. I hope you know now. For adenoma, I want to know which of the four has the adenoma, localize. For hyperplasia, I don't have to localize. For hyperplasia, I'll do Miami. Because there, I want to know, have I removed all four? Because if I don't remove all four, he will have persistent hyperparathyroidism. सारे नहीं निकाले, 3 निकाला. One that I removed was actually fat by mistake. He'll have persistent. Hypercalcemia will happen again within 6 weeks. Now the question I had asked you earlier. Here I am saying reimplant in brachioradialis. If all four are removed, if I am doing total parathyroidectomy, reimplant in brachioradialis. Whereas earlier the question was where I did thyroidectomy and I removed parathyroid accidentally, where did I reimplant them? Accidentally removed were reimplanted where? Yes, Nural, you are asking me Tavi. If I remove them accidentally during thyroidectomy, where did I put them back? Yeh funde. Yes, SCM, absolutely right. So can you tell me here also why am I not putting in SCM? What's the difference? Tavi I put in SCM. Here I am putting in brachioradialis. Why? Or this is some mistake in Bailey or in my making the slide. I have not made a mistake, nor has Bailey made. It is very sensible. Why here I put in brachioradialis, whereas when I did thyroidectomy and मैंने गलती से सारे निकाल दिए because they are close, there I put it in SCM. Blood supply related. अभी निकाल दिया तो निकाल दिया ना, blood supply का क्या connection है? हाँ? Yes, Akanksha Nag, late comer. What's the connection? Akanksha, your junior Mihir is giving lot of answers. Easy to check PTH in peripheral veins? No, absolutely not. I will give you half marks for that. If gland is left behind, we will be able to differentiate. No, neither. Understand, when I am removing normal parathyroids accidentally, I can put them back wherever because they are not diseased. Here they are diseased. Okay, here they are diseased, which means if I put some back, the disease can come again in the parts that I put back. The hyperplasia can happen even in the graft. I mentioned a test over here, carcinoma test. This test is to identify if whatever I removed, if I put it in the forearm, did it become hyperplastic again? That is carcinoma test. So if I put the glands which were diseased in the forearm, as Akanksha said, it is easier to identify graft hyperplasia. Okay, and not just easier to identify, easier to treat. That's why half marks. If it's in the brachioradialis, local anesthesia, I can remove everything. If I put in the neck, resurgery, difficult. So there are two reasons why here I am putting them in brachioradialis. Easy to diagnose hyperplasia or recurrence of disease, as well as easy to treat. So easy, brachioradialis, no anesthesia. Just do a local exploration and remove. End of the story. Okay, now quickly we'll do some adrenal tumors very quickly. See, I told you, I never thought we will finish in 1 hour. There is so much matter in these things. We'll do 2, 3 questions are there. We will finish them. Most common tumor from adrenal gland. Okay. Yeah, so most common tumor from adrenal gland, please remember, it's not any Cushing or PO. No, Akanksha, it's not metastasis. I have written arising from adrenal gland, Akanksha. Arising. It is non-functional adenoma. Oops. Yes, oops. 70%. Okay. If the question was most common functional tumor of adrenal gland, then the answer is Cushing's adenoma. Most common functional. Okay. So about the adrenal, most common adrenal mass arising adenoma, functional tumor Cushing's, any non-functional tumor, if more than 4 centimeters, they have to be excised. You know you have the outer cortex which has different zones and you have an inner medulla. Okay, your cortex has 3 zones. GFR है जिसका mnemonic glomerulosa, fasciculata, reticularis, GFR. G produces aldosterone, F produces cortisone, R produces androgens or sex hormones. Okay, the dictum is the inner you go, the sweeter it gets. Don't quote me saying this. The inner you go. So salt, sugar, sex. The medulla produces catecholamines. We know all that. Epinephrine, norepinephrine. Tumors can come from any of these. It can come from aldosterone producing tumor. It can be cortisone producing tumor. It can be sex hormone producing tumor, or it can be medullary tumor. Tumors arising from the medulla, those are your pheochromocytomas. Alright, those are your pheochromocytomas. Okay, new question from Bailey. New question. Inoperable lung cancer, weight gain. You know, cancers में weight loss होना चाहिए. Weight gain, deranged blood sugars, elevated ACTH. What will you do? It's a hypothetical question, but it's a new question. It will test some fundamental. It's based on a fundamental. It's not a very conventional scenario. If I give you the conventional scenario, then it's not really a question. Then it becomes halwa. But I will never give you halwa. Inoperable lung cancer. Why would that person get weight gain? What is this elevated ACTH? Yeah, BBA. Oh, yeah, paraneoplastic. Absolutely right. What is the tumor? What? Yeah, ectopic ACTH. But what is the tumor which is causing the ectopic ACTH? Which tumor is that? Small cell, excellent. So small cell cancer of the lung. Absolutely right. Produces ACTH sometimes, which has caused Cushing syndrome. Okay, this hyperglycemia, weight gain, buffalo hump, it's all because of Cushing syndrome. Excessive production of ACTH, ACTH cortisol, cortisol Cushing's. Ideally, you would have to treat the tumor, but I have made it one step harder. Inoperable. Inoperable. If it's inoperable, what will radiotherapy do? Nothing. Okay, radiotherapy is not going to help. It may shrink the tumor, may not shrink the tumor, but Cushing's will remain. ACTH production will still be high because this is ectopic. Transsphenoidal pituitary. Why would anybody even mark this? ACTH is not coming from pituitary in this case. It is coming from the tumor. So why would I remove the pituitary? If the tumor is producing ACTH, you will make the life of the person miserable if you do transsphenoidal pituitary excision for a ectopic ACTH production. You will be sued in court of law. Really speaking, you just want to control the Cushing's. C could have never been the answer. Answer is bilateral adrenalectomy. The line given in Bailey, I'll quote Bailey. The line given in Bailey is ACTH dependent ectopic tumors. Either the treatment is either treat the tumor, which in this case is small cell lung cancer, or bilateral adrenalectomy. You start with medical management. But what about the other hormones secreted by adrenal gland? This is inoperable and there is no other treatment. Okay, catecholamines are produced in many places. He will require cortisone supplements. Adrenalectomy करते हैं, ऐसा नहीं है कि नहीं करते हैं. It is a known treatment bilaterally. Okay, this is the line given in Bailey on which the question was based. Similar scenario is given in Sabiston also. Sabiston भी मैंने पढ़ी, उसमें भी ऐसी कुछ दिया. Just few MCQs on Cushing syndrome. This you will learn in medicine. Most common cause of Cushing syndrome is factitious, means person is taking exogenous steroids. Okay, he's taking exogenous steroids, means tablets or whatever. Cushing's disease means endogenous. So either it will be because of ACTH pituitary or ACTH from ectopic tumors like small cell, or it will be increase in cortisone due to tumor in adrenal tumors. Alright, so if someone is having Cushing syndrome and he is not taking the tablets or any source of external steroid, you will think, is it in the brain, pituitary tumor? Is it some ectopic ACTH production? Or is it adrenal production? ये तीन ही जगह हैं जहाँ से cortisone आएगा. If you are suspecting. Now what do you go? First thing you do is you are going to do a screening. Screening is with 24-hour urine cortisol. 24-hour urine cortisol. This is more medicine, but trust me, life will become very easy. 24-hour urine cortisol will increase. Tells me he is having increase in cortisone. This you can confirm if you want with those evening cortisone levels 4 p.m. wale, they will also be elevated. So you know he is having Cushing's disease or Cushing's syndrome. Now I want to know what is the site. Is it coming from the brain, pituitary? Is it some other tumor? Or is it from the adrenal gland itself? What should I do next? I'll tell you simpler way, simpler than DEXA suppression. DEXA suppression भूल जाएंगे लोग, confuse हो जाएंगे. Simplest thing to do is measure ACTH. Easy. हमारा question उसी पे तो based है. Measure is ACTH was high, isn't it? Yes, you can do DEXA suppression. Simple thing, measure ACTH. And there are two ways, two things. Either ACTH will be elevated or ACTH will be suppressed. If ACTH is suppressed, that means the source is adrenal, negative feedback. So you will do MRI adrenal to look for the Cushing's tumor. If ACTH is increased, then there are two options. Either it is pituitary or it is exogenous ectopic. First I will do MRI brain. If MRI brain shows the tumor, I got the diagnosis. If MRI brain is normal, only then I think of ectopic ACTH, then I will look for lung tumor and so on. Alright. और हर चीज का इलाज अलग है. Very simplified way of approaching a case with Cushing's disease. Okay, very simplified. You can do DEXA suppression. If you read Bailey, if you read Sebastian, MCQ books, they will make you go left, right, center. पूरा दिमाग खराब हो जाएगा. Just remember the starting point, and the crux of the situation is ACTH. ACTH is high or ACTH is suppressed. Suppressed means cortisol is being produced by the adrenal, hence negative feedback. So ACTH is suppressed. ACTH elevated means pituitary ACTH or ectopic ACTH. And then you can investigate for each of these components. Alright, are we good with this? So we meet again tomorrow. Tomorrow we are going to continue with our cancer series. We are going to do head and neck cancers. So do join me again tomorrow, same time. Please follow me on the Unacademy Educators app. Do give a thumbs up at the end if you like the class. And of course, if you wish to learn more from me, you can use my referral code 10surgery. And you can follow me on the Unacademy Plus platform, where we will be covering surgical topics in detail. Alright, so hope this class was useful. See you